Chapter 16, Fluid and Electrolyte Replacement. The objectives of Chapter 16 that we're going to discuss today are describing the classifications of IV fluids, discussing the major electrolytes, their functions and treatment for abnormal values, and applying the nursing process to the care of patients experiencing fluid and electrolyte imbalances. Fluids. The recommended water intake for a healthy adult is 2.7 to 3.7 liters daily, or 30 to 40 milliliters a kilogram a day. It's a lot of water. I don't know about you, but I certainly do not meet that recommended water intake. Males are at the high end of the recommended water intake. Patients in general lose water daily via respiration, perspiration, urine, and fecal matter. Insensible losses are kind of impossible to measure. It is estimated we lose 1,400 milliliters in urine, 200 milliliters in feces, 300 milliliters via respiration, and 400 milliliters through our skin in perspiration and evaporation. The minimum urinary output for an adult is said to be 0.5 to 1 milliliter a kilogram an hour, or 35 to 70 milliliters an hour for the 70 kilogram adult. Daily water requirements differ according to the patient's age and medical problems. Fluid maintenance for the NPO patient can be calculated as follows, and this is straight from your book. 4 milliliters a kilogram an hour for the first 10 kilograms of weight, 2 milliliters a kilogram an hour for the second 10 kilograms of weight, and then 1 milliliter a kilogram per kilogram an hour for every kilogram of weight thereafter. Using this formula, a 90 kilogram patient would require 3,120 cc's of water. Can you calculate your own fluid needs? Why don't you take a minute and try to do so. As far as bodily fluids, osmolality of body fluids, or the concentration of particles in a solution, we call them isoosmolar, hypoosmolar, or hyperosmolar. Isoosmolar are the same proportion of weight of particles in water. Hypo are fewer particles than water, or less than 280 osmolality per kilogram. Hyperosmolar is more particles than water, and a normal serum osmolality is 280 to 300 molars a kilogram. Tonicity, on the other hand, is used primarily as a measurement of the concentration of IV solutions compared with the osmolality of body fluids. Fluid replacement. Some classifications of IV solution, and you can see these on page 225 in your text. The crystalloids, and we're looking at isotonic crystalloids. These are the lactated ringers. The 0.9 normal saline, or D5W. The hypotonic crystalloids are 0.45 normal saline, 0.33 normal saline, 2.5 dextrose and water. Hypertonic is 3% normal saline, D5.5 normal saline, D5 and normal saline, D5 and lactated ringers, and D10 and water, and D50% and water. Crystalloids are used for dehydration, electrolyte imbalances, and short-term maintenance fluids. Next up, we have the colloids. These are the plasma expanders. We have high and low molecular dextron, albumin 5% and 25%. The colloid solutions contain protein and other large molecular substances to increase osmolality without dissolving in the solution. Lipids are also a form of fluid replacement, as are blood and blood products. As far as the solutions, looking at the isotonic solutions, these have the same approximate osmolality to our ECF, or extracellular fluids or plasma. They are primarily used for hydration and to expand ECF volume. Hypotonic exert less osmotic pressure than ECF, which allows water to move into the intracellular fluid. And hypertonic exerts a greater osmotic pressure than the extracellular fluid, resulting in a higher solute concentration than in the serum. And the hypertonic solutions, as listed above, what they're going to do is they're going to pull water from the interstitial space into the extracellular fluid via osmosis. And just kind of caution here, and you have to monitor those who are getting that hypertonic and all the fluids that are getting fluid in general for circulatory overload, but especially the hypertonic solution. You want to carefully monitor them for signs and symptoms of circulatory overload because of that increase in extracellular fluid. Here's a little diagram on hypertonic, hypotonic, and isotonic that you can check out. I'm big on visuals, and I'm sure some of you are also. There's the crystalloids, and we talked about the crystalloids. Crystalloids are used for replacement of fluid and maintenance of therapy, and there's your examples up there, which we did mention those earlier. The crystalloid solutions contain fluids and electrolytes and are able to freely cross capillary walls. They do not contain any protein. They cause early plasma expansion, but they have a shorter duration of action than colloids. And here's some other crystalloid examples, and we did talk about them earlier as well. The colloid solutions can escape the vascular system and distribute throughout the body, but colloids can't. They are restricted and they stay in the vascular system. They have medium particles that will not separate when still, and you can see some of the examples up here: dextran, the amino acids, heterostarch, and albumin. The lipids, some of the indications of those who get lipids, patients who are NPO, they're not taking anything orally, or they cannot take an enteral feeding for greater than 7 days. They are often added to a parenteral nutrition or a TPN. Patients who have lipids must have a central line, and then they can be added to a TPN, and sometimes they can be piggybacked into the TPN. You must have a specialized filter for the lipids. One of the things I'm going to say about the lipids is we're going to watch very carefully when patients are getting lipids or anything in the central line. We want to be very careful and know that we're handling central lines, that to change a dressing is a sterile procedure. We want to be very careful with our caps, make sure we're wearing gloves at all times with IVs, and being very careful when we are inserting any additional lines into our TPN. Blood and blood products, and by the way, when you get to Med-Surg 2, one of the things we're going to practice is administering blood and blood products. It is exciting when you first administer your first unit of packed cells, but it's scary too at the meantime because patients can have reactions, and we will be talking about that in Med-Surg 2. But as far as blood and blood products, we have whole blood, packed red blood cells, plasma, and albumin. Whole blood and components of them, we give packed RBCs, plasma, platelets, and cryo precipitated platelets. Blood is given for those who have experienced trauma and have had loss of blood, surgery, childbirth, patients who have had cancer and undergone chemotherapy, and these are some of the usages of blood or folks that are going to have blood products. Concerns when giving blood and blood products are watching for hypovolemia, so we're going to be listening to lungs very carefully, reaction when we're given blood products, and especially the hemolytic, which as nurses, we're responsible for running blood, and we will have 2 RNs or 2 nurses that are checking the compatibility of that blood, making sure it's for the patient, their ID number, the right type of blood, the dates, looking at the blood itself, making sure that we don't have any clumps of cells and such, but it's nursing that prevents the hemolytic as far as checking to make sure we have the right blood for the right patient. Other concerns, we watch the H&H for patients who are in need of blood and patients who are going to have multiple units. We're also watching electrolytes very carefully. The approximate volume of a unit of packed red blood cells is 350 milliliters a unit. 1 unit of blood usually elevates the hemoglobin by approximately 0.5 to 1 gram per deciliter, and 1 unit of packed red blood cells elevates the hematocrit by 3 points in general. Nursing process as far as fluid imbalance, we just discussed a little bit that patients are at risk for hypo or hypervolemia in general, patients with fluids or lack of fluids. We want to assess them for histories of fluid volume problems in the past. For instance, patients who are getting units of blood. If a patient, especially our geriatric patient, has had hypervolemia problems, patients might be given Lasix between units of blood. A unit of blood may be divided before giving it, but we're going to watch them carefully for INO, listening to lung sounds, watching on changes of level of consciousness, edema, and such. Looking at their mucosa, is it nice and moist, and so on. Very important. Electrolytes. As far as electrolytes, we have potassium, sodium, calcium, magnesium, chloride, and phosphorus. We're going to talk about each one of these and the importance to our patients and to human beings in general. Up on top, potassium. The regulation of potassium, it is the predominant intracellular So as I was saying, potassium is the predominant intracellular cation. It regulates many metabolic activities, including our skeletal muscle contraction, conduction of nerve impulses, responsible for normal cardiac rhythms. The normal range for serum potassium is 3.5 to 5.0. That's MEQs a liter, and we know that our labs, we can always give and take a little bit on either end. It is more specific for the specific facility. The body doesn't conserve potassium well. Any condition that increases urinary output could result in a decrease in our serum potassium. And it is really important. It has a very narrow therapeutic range, so we want to watch that very carefully. There you go. There's your normal range. We talked about the functions in the PowerPoint before this. Hypokalemia could be less than 3.5. And we want to watch out for signs and symptoms when that potassium is low: nausea, vomiting, arrhythmias of the heart, abdominal distension, soft, flabby muscles. In hyperkalemia, nausea, abdominal cramps, oliguria, or decreased urination, tachycardia. And then later with hyperkalemia, it goes from tach to bradycardia, or a slowed down pulse rate, weakness, numbness, and tingling. Potassium and the correction of the potassium deficit and excess. In orally, we know that with mild low K, we encourage, and it's easier for the body to absorb, some high potassium foods, and these could be things such as white beans are very high in potassium, dark leafy greens, baked potatoes, dried apricots, some fishes, especially salmon. Avocados and bananas are also high in potassium. If we need to give a liquid potassium, be aware that a liquid potassium tastes very vile, and it has to be diluted in water or juice. So we're going to follow it with a large glass of water to enhance esophageal peristalsis. It can be very irritating to the esophagus, so patients should remain upright for at least 30 minutes. And also, if the patient's taking a tab, they're very large, and sometimes we need to break those in half. If the patient is unable to tolerate oral or has severe hypocalcemia, you're going to be giving it via IV. And only diluted potassium chloride may be administered. It is never administered a push. This could be fatal with a patient. And we're going to monitor the IV site very carefully. With all of our IVs, of course, we're going to check placement first and make sure that IV is patent. IV potassium is a vesicant. A vesicant means that it's very irritating and can cause necrosis if it irritates or infiltrates. This is called extravasation of the IV. We want to use a central line if at all possible. K is very painful peripherally. Meds for hypocalcemia. Some of the meds for K, most of the meds you're going to see K in the name, such as K-tab, or you're going to see potassium in the name, potassium chloride, K-lor-con is potassium. Meds that are given if the potassium is high, K-exalate. K-exalate is an orangey syrup type. It is given PO or rectally to bring down the potassium. Sorbitol is given to bring down the potassium. It causes diarrhea. IV, as does the K-exalate, and that is something you got to talk to the patient about. It will cause a massive amount of diarrhea. And for instance, some of our patients who have ongoing high amounts of potassium at times, they have to take K-exalate several times a day. And so you have to make them aware this is the way the body is ridding themselves of the potassium by having a lot of diarrhea. Also can be given as IV sodium bicarb, IV calcium gluconate, or IV insulin and glucose. If the potassium is less than 6, they would use that K-exalate, and it does take 4 to 6 hours for onset, and it will decrease the potassium by 1 MEQ in 24 hours if it's given 3 to 4 times per day. Or to bring down that potassium, you will see it given several times, possibly up to 3 to 4 times per day. And like I said, it's thick and sweet, and patients hate the taste. Insulin and some of the other IVs, such as IV sodium bicarb, the calcium gluconate, will only be given up in the ICU generally, where they can monitor the ECG ongoing. They will be monitoring their heart, and they will be doing their labs frequently. Nursing process, as far as the potassium, we're going to think about the assessments that we talked about earlier, the lab assessments. We're going to think of diagnoses such as an altered nutrition. We might think of patients who have high potassium, such as patients who are in renal failure in MedSurg 2. We're going to be talking about that a lot. We're going to be planning and talking about diet, talking about restrictions, teaching patient what foods have high potassium so that they can either take it in or restrict it, monitoring labs, talking about and encouraging the patient related to their I&O, checking vital signs, listening to heart sounds, and such. After potassium, the next electrolyte we're going to talk about is sodium, and sodium is the most abundant cation in the extracellular fluid. The sodium is regulated by dietary intake for the most part. A normal extracellular sodium concentration is 135 to 145 milliequivalents per liter. We know our geriatric patients, for one, generally have problems sometimes with hyponatremia due to changes in their kidneys, sometimes over drinking fluids, and we want to watch very carefully. And sometimes in our geriatric patients we will find a change in orientation because of that hyponatremia. There's your normal range, 135 to 145. Hyponatremia is less than 135. Signs and symptoms of low sodium: muscular weakness, headaches, lethargy, confusion, seizures, abdominal cramps, nausea, vomiting, tachycardia, hypotension. Hypernatremia is more than 145, and signs and symptoms with that, we might see they have flushed, dry skin, they might be agitated, elevated body temperature, elevated BP, rough, dry mucosa, nausea, vomiting, anorexia, tachycardia, muscle twitching, hyperreflexia. Foods that are high in sodium. Most of these we will be well aware of: canned products, bacon, beef cubes, ketchup, one of my favorites, corned beef, decaf coffee has a fair amount of sodium, ham, tomato juice, dill pickles, soda crackers, anything with visible sodium as well, such as pretzels and such. So potassium, sodium, and now on to calcium. Calcium regulation. Calcium is stored in our bones and plasma. 1% of our calcium only is in the extracellular fluid. It is used for blood clotting, cell membrane integrity, cardiac conduction, and transmission of nerve impulses. Functions you can see in front of you: normal nerve and muscle activity, contraction of the heart muscle. It is needed for our formation of bone and teeth, and vitamin D is needed for calcium absorption from the GI tract. There's your normal levels. We talked about the function already, promoting that normal nerve and muscle activity and heart contractions, aids that, promotes our blood clotting. And so on. The way calcium is administered is orally, and it can be given IV as well. Hypercalcemia is more than 5.5 milliequivalents. We might see the flabby muscles, pain over bony areas, kidney stones. Clinical management of calcium imbalance, we might be holding, or so as I was talking, clinical management of high calcium is we want to correct the underlying cause of the serum calcium excess. Some of the drugs that your text goes through are the calcitonin or IV saline solution administered very rapidly and followed by a loop diuretic, can be used to promote rapid urinary excretion of calcium. Some of the drugs that have an effect on our calcium balance include phosphate preparations, or steroids, loop diuretics, aspirin, anticonvulsants, magnesium. Excessive calcium salt ingestion or infusion and thiazide diuretics can all contribute to an increased serum calcium level. We've already I touched on that correcting the treatment, the calcitration or the IV, and the loop diuretic. Next up is magnesium. Magnesium has a very low percentage in our body. It's 1.5 to 2.5 milliequivalents a liter, or 1.8 to 3 milligrams a deciliter. Function: it promotes transmission of neuromuscular activity, promotes cardiac contraction, activates enzymes for metabolism of protein and carbohydrates. It promotes transportation of sodium and potassium across the cell membranes. Hypomagnesium is less than 1.5 milliequivalents a liter, or 1.8 milligrams a deciliter. With a low magnesium, we're going to see an increased neuromuscular excitability, loss of deep tendon reflexes, cardiac dysrhythmias, hypotension, hypermagnesium. For a correction of a magnesium deficit, we're going to be given IV magnesium, and calcium gluconate can also help. It is probably the most undiagnosed hypomagnesium, the most undiagnosed electrolyte deficiency, and this is most likely because low magnesium is asymptomatic until the serum magnesium level approaches 1 MEQ a liter. Total serum magnesium concentration is not representative of the cellular magnesium levels. Some of the effective drugs on magnesium balance: sodium inhibits tubular absorption of magnesium and calcium. Long-term administration of saline infusion may result in losses of magnesium. Certain diuretics, antibiotics, laxatives, and steroids are drug groups that promote loss of magnesium. Excessive intake of magnesium salts is a major cause of serum magnesium excess. Commonly used meds that can cause hypermagnesium are laxatives and antacids, and especially our patients who are on dialysis, we will be very careful of any laxatives we give them and antacids, because they can, their magnesium level can go up pretty quickly, and they're not going to rid themselves like others with working kidneys. There you go. Hypomagnesium, some of the causes. You got your dialysis, kidney disease, diarrhea, prolonged IV feeding. Patients with low magnesium may also present with hypocalcemia and hypokalemia. That's the end of chapter 16 for us on the fluid and electrolyte replacement. Hopefully most of this has been a review for you all. I will see you and talk with you for chapter 17. Thank you very much.